and that movie Black shows how gradually there is a changes in memory, how the memory loses, the memory loss is there, and how it affects the person's day-to-day life. So this is very clearly depicted in that. So how it is there, what are various mechanisms? I told you there are many things are there, like we call it as a neurofibril tangles, tau proteins, there are various plaques are there. So these are various things which are known, which are which are believed to change the system in the brain of the person, and this causes the Alzheimer's disease. It has been, I told you about how memory is there, and actually nobody has answered so far. And it's very unfortunate that very few people try to answer the queries and answer the assignments. Memory basically is again a sort of neurotransmission. Memory is form of neurotransmission, and that memory is recorded in that form. And it has been found that it has been observed that acetylcholine plays very important role in this memory. So acetylcholine is available. We know about acetylcholine. We have seen the cholinergic system earlier when we have studied ANS, and in that we have seen how acetylcholine is produced, how choline is taken back, how acetylcholine acts on receptors, how acetylcholine esterases are there which causes metabolism, and how acetylcholine esterases, if we inhibit, there is an increase in the acetylcholine level in the synapse. And there are various other cholinesterases are there. Example of this, one of these is a butyryl cholinesterase, which is present in the nearby surrounding cells. We call them as a glial cells. So these glial cells will secrete this butyryl cholinesterase, and it is also acetylcholinesterase like activity, and this will also cause metabolism of acetylcholine. So this is what we have studied earlier, we have seen it. Now it has been observed that it is found that this acetylcholine producing neurons, they are getting damaged. Just like in Parkinsonism, we have seen that dopaminergic neurons are getting damaged. Here it is because of that presence of various plaques, or presence of this beta amyloid or its precursor protein, we call it as a amyloid precursor protein. These are causing the inflammation around the plaques, and these are particularly affecting the cholinergic neurons. And then one more mechanism is there, that is tau is one type of plaque, and neurofibril tangles are there. So they are present over there, and they are affecting, they are causing it. Now let us see various drugs which are acting. Most of the drugs therefore are having same mechanism of action except one, that is memantine. Most of the drugs which are having the action is acetylcholinesterase inhibition, just like we have seen earlier. If you remember, we have seen earlier various acetylcholinesterase inhibitors in various treatments, including myasthenia gravis, etc. So here also these are there. Only difference is what this whatsoever acetylcholinesterase inhibitor we are using for Parkinsonism, they are crossing blood-brain barrier. They are having more activity comparatively in brain, and therefore they are having more activity in brain because of their pharmacokinetic and dynamic features, and therefore they are treatment of choice. So we have various drugs. Example of this is donepezil, rivastigmine, galantamine. Galantamine is the older one. After that, this newer drug came. They all are acetylcholinesterase inhibitor. It can act selectively. It can be reversible in nature. Donepezil is selective on cholinesterase inhibitor. That is acetylcholinesterase. It can act on both. This rivastigmine can act both, but it is irreversible. Here irreversible is also beneficial. We have seen organophosphorus compounds, they are irreversible and they causes toxicity. We have seen they are poisons. Here slightly irreversible, if it is there, it also helps. In what sense? That is because the long duration of action. Then galantamine is also having activity. It is selective in nature, acetylcholinesterase, and it is acting in reversible manner. And one more drug is there which is having different mechanism action, is a memantine. So memantine is having action, that is, it is NMDA receptor antagonist. The other mechanisms this drug can have, rivastigmine is also having butyrylcholinesterase inhibition activity. We have seen butyrylcholinesterase that it is present in the glial cells, and it is additionally causing metabolism. Then the other one is galantamine, which is a nicotinic modulator, and memantine also show 5-HT3 receptor antagonist activity. So because of all these different activities, the drugs are showing their actions. The doses are there, treatment you can go through. Now how we can increase the doses? Suppose we see that effect is not there, then we have to wait for at least 4 weeks, and then we can increase by 5 milligram daily dose which is there. So again, when initial dose will be 5 milligram, suppose here, then you can go it after 4 weeks, you can make it for 10 milligram, wait for 4. Okay, usual treatment dose is 10 milligram per day. If it is the rivastigmine, then it is 2 weeks for the oral increase, and you can increase by 1.5 milligram. For 4 weeks for patch drugs which are there given by, and the galantamine, it takes 4 weeks for increasing the dose, and here it is, in case of memantine, it should be 1 week. Adverse effects are there which are comparatively very common, which is having more than 1 in 10%, or which are common, which are around 1 in 100. So in between very common and common, we can have like diarrhea, nausea, headache, common cold, anorexia, hallucination, agitation, aggressive behavior, abnormal dreams, nightmares, syncope, dizziness, insomnia, vomiting, abdominal rashes, abdominal disturbances, rashes, pruritus, muscle cramps, urinary incontinence, fatigue, pain. These are various types of adverse reaction these drugs are causing. Then another is anorexia. This drug is causing, that is rivastigmine, causing dizziness, nausea, then vomiting. So those which are having star, they are very common. That is anorexia, dizziness, nausea, vomiting, diarrhea, they are very common. Somnolence is daytime sleeping, Saba. So these are various diseases, these are various adverse effects, they are there. Again, nausea, vomiting, appetite, decreased appetite, anorexia, hallucination, depression, syncope, dizziness, tremor, headache, etc. Drug, hypertension, somnolence, dizziness, balance disorder, hypertension, dyspnea, constipation, elevated liver function test. These are various adverse effects. Memantine has got comparatively more adverse effects. If adverse effects are too more, then one can stop the treatment. If the following adverse effects occur, like bradycardia, gastrointestinal ulceration, reduce dose or discontinue it if intolerable. If the following adverse effects occur, nausea, vomiting, diarrhea, we can reduce the dose. Now all this, as I told you, these drugs we have seen already their mechanisms, that is basically all these anticholinesterase inhibitors, how they act. They block the, or they offer themselves for the metabolism before acetylcholine, and therefore acetylcholine metabolism decreases, and thus concentration of acetylcholine in synapse, that will increase. Then earlier tacrine was also given. Tacrine is sort of organophosphorus compound. It was there for the treatment for mild to moderate Alzheimer's disease, but it is no longer prescribed because it has got poor tolerability and it has got risk of hepatotoxicity. So as I told you, even irreversible we could have preferred, because we want it for long duration of time, but unfortunately they have more adverse effects. So there are 3 important drugs which are there in first line, that is donepezil, rivastigmine and galantamine. They differ in their pharmacological actions, because some are acting on acetylcholinesterase, some are acting on pseudocholinesterase, example rivastigmine, and others are also having action on butyrylcholinesterase. So these are having different kind of activity, and therefore Uh, then again it can be reversible, irreversible, as we have seen earlier. Plus this galantamine also having nicotinic acetylcholine receptor activity. So these are various activity which are there, and there is a this nicotinic acetylcholine receptor, they are largely contribute to overall reduction in the central cholinergic neurotransmission. The last mechanism is also considered important in the treatment of Alzheimer's disease. That is, it acts on just. So this is how the drugs are acting. The memantine is acting in a different way, that it is acting on NMDA receptor, and through this NMDA receptor it will have the neuroprotective activity. It has been found that all these drugs, they can have various guidelines. They have shown that these all drugs are very useful in that way. At least they can prolong the problems. It makes it delayed for some time, and therefore they are quite useful. They are having so many interactions, again, drug interaction will not go in more detail, but it can be absorption related, it can be metabolism related, it can be distribution, that is plasma protein binding, etc. And it can be related to excretion, etc. So there are various drugs, it is showing interactions. So whenever these drugs are given, it has to be seen that the other drug whatsoever is given, it should be taken care of to see the changes, make the impact what is there. Now apart from that, it is believed that further new drugs are in process. Some drugs will be available for various treatment or various mechanisms. Example, it has been found that amyloid overproduction is one of the cause in the Alzheimer's disease. It has been detected. So it has been found that the drugs like statins or secretase inhibitors, they are underway, they are being studied whether they can be useful. Then it has been again one more mechanism, that is there is amyloid plaques are deposited in brain, and because of that there is a damage of that. So for that some vaccines and metachelators are being studied, or it has been underway to check whether we can reduce it. Some inflammatory responses, like we can see that whether these anti-inflammatory agents like NSAIDs, COX-2 inhibitors can be used, which can reduce the inflammation, and because of decreasing the inflammation process we can reduce it. Then tau kinase inhibitors, again tau protein, as I told you, it is one of the causative feature in the Alzheimer's. So tau kinase inhibitor, whether it can be used. Tau aggregation inhibitors are there, it has been studied. Then neurofibril tangles are there, which are formed. So far no drugs are being tested on that. But yes, on neuronal cell locks and neurotransmitter changes, again a newer acetylcholinesterase is being studied, that is dimebolin is being studied. So these are various reasons for Alzheimer's, or these are various causative factors are known, and the new drugs are being studied. So in Alzheimer's we don't have too many drugs, we have only limited number of drugs at present available, and almost of that most of sharing same mechanism of actions, and by that virtue it can act, it can be helpful. So this is how the drugs are there. This is the drug acting for Alzheimer's. I'll suggest you to go through various videos already, last year's lectures which are already been uploaded over there. You go through that, so you will be clear, you will have ideas about CNS. In the meanwhile, we can start back, or we can go back to our therapeutic classes, so that we can start some of the topic. You just suggest me, you let me know which topic you would like to continue after this. So we'll go for the topic that is from any topic from the therapeutics after this. Okay. But whenever we'll go for that topic, I'm expecting that you have read the things and you know about it. So go through it, and if you have any difficulty, you can ask me. Okay. Hmm. Yes. Okay. It was. Thank you. Very good. Everything is fine going? Okay. Hard was not. Okay. Okay. Thank you.